Thank you so much, Mariam, for such a nice and knowledgeable presentation. And next to her, I want to move cardiogenic shock is another life-threatening condition usually seen in cardiogenic patient. How these patients are supposed to be treated, we call Dr. Ayesha Tariq to present his views.
Assalamu alaikum. I'm Dr. Ayesha Tariq, working as Assistant Professor of Cardiology at King Edward Medical College, Myon Hospital, Lahore. I welcome you on board on behalf of Pakistan Society of Interventional Cardiology in this academic session. Hope that you gain some knowledge out of this session and you go back and just apply the knowledge being taught in this session. This is just the aim. So my topic is management of cardiogenic shock, nursing perspective. So everybody knows cardiogenic shock is inadequate contractility of the heart leading to hypoperfusion of the tissues and organ damage. There are various types of shocks like hypovolemic shock, cardiogenic shock, obstructive shock, and distributive septic shock. So our topic of interest is cardiogenic shock. What are the causes of cardiogenic shock? Causes are mainly, they may be filling defects, diastolic heart failure, problems with contraction of the heart like cardiomyopathies, heart failure, myocardial infarction, ischemia, arrhythmias, conduction abnormalities, structural valvulopathies. These contribute a lot to cardiogenic shock. What are the signs of cardiogenic shock? One should be aware of it. Patient may present with angina, decreased blood pressure, increased heart rate, cold clammy peripheries, sweating hands, increased cardiothoracic ratio on chest X-ray, pulmonary edema, increased JVP, peripheral edema. This slide, my purpose of showing this slide of Caleb classification in cardiogenic shock has significance because you see the classification of Caleb classification, hemodynamic classification in acute myocardial infarction. There are 4 subgroups. Type 1, stage 1 के लिए, no congestion signs. 2, S3 basal crackles, 3rd heart sound being heard. 3, acute pulmonary edema. 4th is cardiogenic shock, which is the end of every myocardial infarction that is being complicated by shock. And it carries in-hospital mortality about 81%. The significance is if you don't diagnose it early, you don't treat it. And if you are unable to treat the patient with cardiogenic shock early, you will lose the patient. Time is myocardium. You need to salvage the myocardium as early as possible and as much as you can. This is my point of showing this slide. So diagnosis of cardiogenic shock. The patient is in shock. You need what blood tests should be done, what investigations should be ordered so that we can reach a diagnosis. Serum lactate levels, chest X-ray, central venous pressures, arterial blood gases, EKG, PCWP, troponin levels, echocardiography, and then diagnostic coronary angiography. Treatment of cardiogenic shock. So the aim should be to diagnose it in time and treat the patient in time so that we can be able to find the underlying cause and send the patient back home. Speed up the recovery. Patient should be admitted in coronary care unit. IV line should be taken. Oxygen therapy if he is not maintaining oxygen saturation at room air below 93%, he needs oxygen therapy. Cardiovascular support, increase systemic vascular resistance. You need to give vasopressors. Systolic blood pressure is less than 70, less than 90 millimeters of mercury. Patient is cold, clammy, pulseless. What to do? Improve contractility, give inotropes, dobutamine. Fix arrhythmias by either pacing or giving antiarrhythmics. Then comes the turn of advanced devices, LVSS devices, IABP, Impella, echo, whether the patient requires PCI or not, so that he comes out of shock, he recovers out of shock, he has a resistible cardiogenic shock, not showing any improvement with inotropes or vasopressors. What to do next? Do you need heart failure devices? Do you need to have heart transplant or not? This is just an overall view to show that there is preload and afterload on heart. Heart is stressed out. How to balance between preload, whatever blood is coming should go into the lungs and should go into LV after oxygenation. Once LV is damaged, blood is unable to move out of aorta, great vessel, to the peripheries. You need to have this balance. You need to decrease the preload. You need to decrease afterload if by giving AS, ARBs, if there is imbalance. You need to diagnose at first and act accordingly. Again, the same slide showing how preload, afterload, or contractility has got its impact on stroke volume, on heart rate, on cardiac output. This is a slide that shows you need to have your eyes on monitor to see whether there is bradyarrhythmia, tachycardia going on, patient's pressure is going. How many times you see in a cath lab, the primary operator is working and suddenly your tech tells you, madam, pause, bradycardia, madam, hypotension, pressure drop, patient ko kahin cuff kare. This is the response I want you people to take it home from this session. You should be sharp enough to identify it. Your eyes, your mind, your brain, and your hands should be working together. What to do next? If the patient is deteriorating, what to do next? What will be your next step? What is the underlying cause? Why he is not responding to inotropes? Why he is not responding to our treatment? Does he require, are we missing something? So this should be your response. Next, inotropes and vasopressors. This slide, I need you to memorize it. Why? Because most of the time, the patient presents in ER, in coronary care unit, after cath lab, he is received in coronary care unit, and he is pulseless, BP-less. After the procedure, after plasty, after acute MI, after having chest pain, he lands in ER. So, ACC-AHA guidelines say if systolic blood pressure is less than 70 millimeters of mercury, you should infuse norepinephrine first. Norepinephrine, 0.5 to 30 mics per minute. Switch to dopamine once blood pressure is around 80 millimeters of mercury. And again, the dosage of dopamine, 5 to 15 mics per kg per minute. If blood pressure at presentation is between 70 to 100, you need to infuse dopamine, 5 to 15 mics per kg per minute. Add dobutamine once blood pressure is above 90 millimeters of mercury. So, starting with, if systolic blood pressure is less than 70, go for vasopressors. Systolic blood pressure is between 70 to 100, go for inotropes, right? Refractory hypotension and shock. Ambrinon, milrinone may improve cardiac output. You may need phosphodiesterase inhibitors. Levosimendan, preferable if patient is on chronic beta blockers, not responding. So it is, again, same slide reinforcing what does European Society of Cardiology say about it. Short-term infusion of inotropes if systolic blood pressure is less than 90, sign and symptoms of hyperperfusion, and to increase cardiac output, it should be given. This is the failing heart. This is the dying heart. You need to save this. You need the heart to get out of this shock state. If you act promptly, you need to act promptly to get this situation in your hands, in your control. Again, reinforcing on the mechanism of action. You know, dopamine has got its impacts on dopaminergic receptors, beta 1, beta 2 receptors, alpha receptors. Dobutamine has got its impact not on dopaminergic receptors, only on beta 1, beta 2, and alpha receptors. After the inotropes, we have vasopressors, we have norepinephrine, epinephrine having impact on alpha beta receptors. So this slide just reinforces your pharmacological knowledge when to infuse which drug according to the state of the patient. Again, same slide reinforcing which drugs have impact on systemic vascular resistance and improving cardiac output. So this flowchart is when patient presents with acute severe cardiogenic shock, you need to start an inotrope. If the patient's hemodynamics vitals improve, no need to go on the advanced treatments. If hemodynamics remain poor, you need to start a vasopressor. If there is response with the vasopressor, no need to go on advanced treatments. If there's no response with that vasopressors, again, you need to think more meticulously. Should we go with the LVAD? Shall we go with IABP? Shall we go with Impella device? If with these devices, hemodynamics improve, continue with it, wean off the sports. If they show no response, then you need to think of higher level mechanical cardiovascular supports. So, I have a timer, sorry. So these are the slides again, patient presenting with acute heart failure with hypoperfusion, cardiogenic shock algorithms, what to do, identify the cause, what are your goals, what is the shock criteria, same reinforcing the same slides again and again. So the last slide I would like to do, where nursing intervention comes. Maintain strict fluid intake output measurements, monitor daily weight, assess for edema, swear diaphoresis, monitor electrolyte values, hematocrit levels, maintain strict fluid restrictions as prescribed, restoring intravascular volume, infusing vasoactive drugs, mechanical support, maintain vitals until recovery, adjust therapy according to vitals. And these are just the advanced devices I want to show you, IABP. Just place distal to left subclavian artery, ECMO device. And the goals of management in cardiogenic shock is to slow down its progression, reduce the cardiac workload, improve cardiac function, and control fluid retention, attaining the euvolemic state. Complications, everybody should be knowing, there may be multi-organ failure and organ damage. This is my last slide. Take-home message. Cardiogenic shock is treatable illness with a response chance of full of recovery. The literature shows high mortality. It is important to recognize that although patients with cardiogenic shock are at very high risk for early death, great potential exists for salvage. This is your take-home message. And thank you everyone for welcoming us in your beautiful city, our capital city of Islamabad.